Okay, we're going to be going over the nasal CPAP CBO today. Um, Basically everything you have to know and what's expected of you to pass the CBO with the instructors, or RT. Um, so we're going to go over the machine first, just show you all the basic buttons on it. So you can select your FiO2 right here. You select your flow right here with this little knob and you can see the flow, what it's set at. There's the alarm button, we'll go over that afterwards. There's what the FiO2 is actually reading and what the CPAP level is. Yeah, so what we're going to go over first is basically what nasal CPAP does. It's used to increase FRC, increase lung compliance, it recruits alveoli, and improves oxygenation. The big indications for it are apnea of prematurity, so it stimulates the baby to breathe, respiratory distress syndrome, or RDS type 1, atelectasis, like I said, it recruits alveoli. A lot of people post-extubation go straight to this instead of just a little bit of oxygen. And tracheomalacia, it can also be used for, it just holds the airway open a little bit. The only real contraindications for it are pneumothorax, diaphragmatic hernia, and choanal atresia. So we're going to go over the setup now. So we already have the baby hooked up. Okay. So one thing you should always do when hooking up nasal CPAP is you always want to insert an orogastric tube to alleviate any gastric distension. Gastric distension can push up on the diaphragm and limit lung expansion. It can also cause the patient to throw up, possibly causing aspiration pneumonias or, yeah. So you measure the length of the OG. I'm just going to show you the OG. You go from, depends which center you're at. I've seen oro or nasogastric from the corner of the mouth to the tragus, so from the ear to the xiphoid. So and that's the distance you're going to go down. Once you do insert it, you're going to put a little syringe on it with 2 cc's of air already hooked up. You're going to have your stethoscope listening over the belly, and you're going to push the 2 cc's in, and hopefully you'll hear that little like push of air. If you don't, the orogastric tube is most likely in the lungs. So if you do hear it, you're going to withdraw the 2 cc's that you put in. Disconnect the syringe. You're going to take the back part off. Some people put a little cotton ball in there. And you're going to reconnect it. And basically just have it open atmosphere to vent any gas that gets pushed into the stomach. So,
no, I neither did the start for the other team. Neither I scored.
Really?
The 2 leading scorers in the league.
Before you set this up, you always want to verify the doctor's orders and get all the equipment ready. Usually someone's providing the baby with some sort of blow by oxygen or a PEEP with like a flow inflating bag or anything really. You want to aim for physiologic PEEP to start. So if you get a flow of 8, it should give you 4 to 5, which is what we have set up now. So you can see the flow is at 8 and the PEEP is at 4 right now. So that's pretty much where you want to start. If you have it at 8 and you're not getting 4 to 5, if it's much lower, you should look for a leak. There's most likely a leak. Yeah, you don't want to turn the pressure up. So you should always test it before you hook it up to the baby. So block off the end and make sure it's reading 4 to 5. So if you hook it up right away and you're not getting that, you know there's most likely something wrong at the other end and it's not the circuit that's leaking. So to size the prongs or mask, you're basically going to use this little sheet right here. The prongs, you're basically going to match it up with the baby's nares, and you want it to cover almost the entire nair. Or the mask, you match it up with the face, and it tells you exactly which one you should use. Small, medium, large, extra small, extra large, extra, extra large. So usually most centers will switch between these every day, just so that you don't hurt the baby's nose or face. Yeah. And with the infant flow system like we're using now, it comes with a little hat to hook the nasal CPAP system up. They come with a little measuring tape like this, so you measure around the baby's head, and whichever color it comes to, that's what size hat you would use. That part's pretty easy. So once you do hook up the baby to this, you want to do a quick little ABC and make sure you're getting good air entry, stuff like that. Make sure they're tolerating the treatment. So once the baby's fine and everything's hooked up, we're going to go back to the ventilator. And to set the alarms, once you're happy with the FiO2 and PEEP, to set the alarms, there's a little alarm button right here. You hold it until you hear 3 beeps. Yeah, and let go. That basically sets it so that the alarms are 5 above and below the set PEEP and FiO2. So you always want to document appropriately, so including vent start sheet. You'll be expected, well, during the CBO, you'll come back and the baby will be in distress. So he wants you to look at 4 possible things. The biggest thing he wants you to check is if the prongs are blocked, if the baby has secretions. Even if the prongs are blocked, you will still hold the pressure of 4 to 5 PEEP. So, and babies are nose breathers, so they're going to get distressed very easily if the prongs are blocked. So, you check that. It can also be caused by pneumothorax, cardiac tamponade, or hypovolemia, but the biggest one is blocked prongs. So, other stuff we can go over. You start at initial pressure of 4 to 6. If you have to increase it, you go 1 to 2 centimeters of water pressure every couple minutes. The maximum pressure you can use with non-invasive, so nasal prongs or the mask, is 12 centimeters of water pressure. With an endotracheal tube, it'll be 10, although you rarely see them go above 4 to 5. When you do go to wean, you want to wean the FiO2 first and then the pressure. And yeah, that's pretty much everything he expects you to know about this CBO.